All right, hello all. We are going to talk about diabetes in your eyes today. Primarily, we are just going to focus on what we kind of look at as eye doctors when a diabetic patient comes in and for the kind of routine eye exam and what we're looking for, how we classify things, and so on and so forth. So let's begin here. Diabetes is an increasing problem in our nation. Back around 2015, I want to say there was only about 24 million people who had diabetes in the United States. Now we're up to 34 million. I think probably the scarier number is 88 million people in our nation have pre-diabetes, meaning they're borderline about ready to convert over to diabetic patients. But 80% of those people don't even know that they're pre-diabetic because they're not symptomatic or they feel like they're doing pretty well, so they're not going to get their annual physicals and blood work. And so they are just out there and probably won't know that they are pre-diabetic until they're actually diabetic. And so we all know that there are two different types of diabetes. There is type 1, which is more commonly, some people refer to it as juvenile diabetes. We tend to see it a lot more in kids. It makes up about 5 to 10% of the cases nationwide, and it is where the pancreas does not make enough insulin. And when it doesn't make enough insulin, the cells in our body do not get the signal to take the blood sugar and absorb it into them to use for later. Type 1 diabetes, there's no known way to prevent it. A lot of it is just genetics and things like that. And over 10,000 youth are diagnosed with it each year. Type 2 diabetes is the other type. It makes up the vast majority of cases, 90 to 95%. It can develop at any age, and many cases are preventable. On the right, we can see kind of the stereotypical pathway of developing type 2 diabetes. Not all type 2 diabetics are represented by this chart over here, but in America, there are a large percentage of type 2 diabetes patients who do represent this kind of graphic where we eat a lot of junk food in America. That keeps our blood sugar up all day long. And then our pancreas and the little cells in the pancreas are always pumping out insulin to keep up with all of that sugar in our blood. And then eventually the pancreas just can't keep up anymore, and our cells actually become resistant to the insulin that the pancreas is pumping out. And so then we start to become overweight, and then we become hungry and get cravings because A, as our weight increases, that can modify some things and cause you to act more hungry. And then B, if your cells are not utilizing the insulin to uptake the sugar out of your bloodstream, they're starving too. And so then you eat more, and then it's just a nasty downhill spiral from there. And then we end up with diabetes at the end. The risk factors for developing type 2 diabetes: age, nothing we can do about that. If we figure out how to do that, somebody's going to become very rich. And yeah, but so far, we haven't figured out how to stop aging. Family history, genetics, that's another thing, can't really change. If you have a sibling who is a type 2 diabetic, you're at a much higher risk of developing type 2 diabetes yourself. Low physical activity, so if you are going days without getting out and exercising, getting your heart rate up, you're much more likely to develop type 2 diabetes. And then being overweight is the other risk factor. Eye exams for people who are diabetic or could become diabetic are extremely important. Diabetic patients are at risk of having a lot of problems with their eyes that we need to monitor and we need to manage. I think the other really interesting thing is pre-diabetic patients, and remember 80% of those pre-diabetics don't even know that they have diabetes. It's not uncommon when we're doing a routine eye exam on someone who doesn't know that they're at risk for diabetes or that they have diabetes, that we see signs in the back of their eye that indicate that they have possible issues that could be diabetes. And in the United States, there are approximately 320,000 cases of diabetes per year that are kind of found on routine eye exams. So as an eye doctor, what do we look for? What are we looking at when that person comes in for their diabetic exam? Here is kind of our basic eye anatomy. Out on the front, we have our cornea, which is that first clear window in, and then you can see the iris and the pupil, and right behind that is the lens of the eye, which is kind of the second clear window. And then way in the back, you can kind of see those red squiggles, and those are your blood vessels. The back of the eye is the only place in the body that we can actually see your capillaries and blood vessels without cutting you open. And so that's why it's really nice that we can look at your eye and inside your eye with a dilated exam to look at those blood vessels, because if you're having a diabetic change, oftentimes we'll be able to see it in your blood vessels in your eye. So here is a normal retina. Get a good idea what this looks like, because from here on out in the presentation, we probably won't see another normal retina. I don't have too many gross pictures, but we do have some pictures of diabetic changes that happen in the eye. So kind of the circular pinkish yellow structure would be the optic nerve. Of course, all the little red rivers coming out are all the blood vessels and veins. The darker area in the middle is the macula. That's your really detailed part of vision. So when you're moving your eye, you're actually moving your eye to keep that little area focused on what you're looking at. And if you have changes in that area, that can disrupt your vision pretty quickly. So this is a normal, nice, healthy retina. Diabetic retinopathy, there are 3 different types. And we break them into types and classify them because depending on what classification you have, that's an indication of the risk that you are kind of having for permanent vision damage or vision damage in the near future. So the first category is something called non-proliferative retinopathy. That is where the blood vessels that are there and have always been there are leaking out blood and fluid and creating problems. The next classification is called proliferative retinopathy. That is where the retina has started to grow new blood vessels. And those new blood vessels are not very good because they're weak and they tend to leak a lot more fluid. And when they leak fluid and blood, that is actually toxic to the rest of the retina. And so it kills the retina, which is not a good thing because we need the retina to be able to see. And then third, there's a classification, something called macular edema. The macula is that central part of vision that we really has most of our detailed vision. The macula, again, is what we're moving our eye to keep the light focused on. So risk factors of developing retinopathy, the longer that you are a diabetic, the more likely it is that we will see some sort of retinopathy in your eye. It's not uncommon to have a well-controlled diabetic, particularly type 1, who's had diabetes for 15, 20 years. They've done a really good job. They're a nice, healthy person other than type 2 diabetes. And they'll come in and we'll see some retinopathy in their eyes. Very, very normal. Not ideal, but normal for a diabetic patient who's had it for multiple years. Obviously, having poor control of your diabetes can increase the risk of us seeing retinopathy in your eyes. So if the blood sugar is going up and coming way down, or if it's just always up and the patient doesn't really manage it very well, then that can cause retinopathy as well. Comorbidities along with diabetes, such as high blood pressure or anemia, that can also cause us to see retinopathy more quickly. And pregnancy can actually cause diabetes and retinopathy changes earlier. So here we have a picture of non-proliferative. You can see little spots of blood in there. That is a mild case of retinopathy. And the capillaries have leaked out little bits of blood. There's no treatment we do for this as eye doctors other than monitor it. And typically we monitor that in about 12 months. The next stage, going from mild, would be moderate. And here we have those little hemorrhages, but then we start to get other signs such as something called exudate, which we'll cover here in a minute, and cotton wool spots. Again, the treatment is just controlling the diabetes systemically really well. Diet, exercise, medications with your primary care provider or your endocrinologist. Once we get to moderate, then we start to see you about every 6 months. So here's exudate. The exudate would be the little bit of kind of white scattering you see in the retina there. The red splotches would be hemorrhages again. What exudates are fluid, serous fluid leaking out from the capillaries. And that serous fluid has a lot of lipid in, which are kind of yellowish white. So when we look in the back of your eye, we'll see these yellowish white deposits of exudate. Cotton wool spots, you can see, cotton wool spots are kind of fluffier, kind of more like a cloud. What they are is the nerve. So the retina is basically one giant sheet of nerves. And when they become ischemic, because the blood supply is damaged through the capillaries, those nerves will actually start to basically put the contents of their bodies out and die and become damaged. And we visualize that as a cotton wool spot. Over on the other side of the picture, you can see kind of the contrast with exudates. Exudates tend to be a little bit more like yellowish sand thrown in the retina, and cotton wool spots are more like clouds. That's how we differentiate. We can also do some scans to help us differentiate the two if we need to. So we had mild retinopathy, we had moderate retinopathy. Now we have something called severe diabetic retinopathy. There's something called the 4-2-1 rule that we follow. And if you have one of the following, you are labeled as severe. So hemorrhages in all quadrants, meaning when we take that picture of your retina and divide it up into 4, if we're seeing a lot of bad bleeds and hemorrhages all over the retina, that would not be a good thing. You would be qualified as severe diabetic retinopathy. There's something called venous beading. If we look in the picture, the darker red vessels in your retina are the veins. And when they start to look like sausage links, that's called venous beading. So it's kind of focal narrowing and then widening back out. That's a higher risk characteristic too of potential vision loss in the future. And then we have intraretinal microvascular abnormalities, IRMA. If we look in the picture, you can see kind of the looping little tiny vessels. That is actually where the blood is bypassing the capillary beds. And so in that area, in the capillary beds, the cells that are being kind of provided by that capillary bed, they're not getting nutrients. So that can create a lot of issue because those cells are going to become damaged. And the reason that we classify mild, moderate, and severe again is that it is a risk. And the higher the risk and the later the stage, you're at higher risk of developing something called proliferative diabetic retinopathy. When you convert over to proliferative diabetic retinopathy, the risk of vision loss and severe damage to the eye goes up by a lot. So severe diabetic retinopathy, again, nothing we can do eye-wise other than get better diabetic control, work with your PCP, nutritionist, endocrinologist, things like that. But instead of seeing you every 6 months, now you're down to coming in and having to see us every 3 to 4 months. So proliferative diabetic retinopathy, like I stated before, is where the retina is so starved of oxygen and nutrients because the blood vessels aren't working right to provide those nutrients to the cells in the retina, that the retina basically says, we have to figure out different ways to get more nutrients here. And so the cells in the retina will start to release molecules. And one of the main molecules that it releases when it's stressed like this is something called vascular endothelial growth factor, or VEGF. And that is a molecule that'll go out to the other blood vessels and say, this area over here is starving and needs more nutrients and oxygen from the blood. And it'll signal that blood vessel to actually start growing over that way. Kind of like tree roots that are growing down in the soil. Blood vessels can grow if they are stimulated the right way. These new blood vessels are called neovascularization. And the new blood vessel growth you would think could be good because it's going to provide extra nutrients, except it's actually very bad because it usually doesn't provide the nutrients. And they're usually very poor quality blood vessels, and they end up just leaking fluid and blood, which again kills the retina. So here we have an example of proliferative diabetic retinopathy. You can see the arrows pointing to different areas where there's a lot of different little blood vessels all looping around. It kind of looks like some sort of coral reef or sea fan or something like that. Those are all new blood vessels that have grown into the retina and are damaging the retina. So the question becomes, if we have all these new blood vessels and the retina is going to be damaged by them, how do we stop them? One of the mainstays for treating proliferative diabetic retinopathy is actually a laser treatment. So in this picture, you can see a whole bunch of whitish spots in the retina. This is a patient who actually went to a retinal specialist, and all those little spots are actually laser burns. So what the goal of panretinal photocoagulation, which is the laser treatment, is where all of those white spots are, they're going in and burning the retinal tissue to basically kill the retinal tissue. And they're killing the retinal tissue so that they can save the central part of the retina, which is where most of your vision occurs at. By killing so much tissue in your retina, they reduce the amount of cells that are releasing the VEGF molecule. And thus, that reduces new blood vessel growth and helps protect that central part of the retina instead of just everything being destroyed. So they're basically killing some to save some. Diabetic macular edema. So we went through non-proliferative retinopathy. Then we had our proliferative retinopathy with new blood vessel growth. Diabetic macular edema can happen with either category. What macular edema is again that central part of the retina where it's a little bit darker. In these pictures, you can see inside the center of the green circles would be the macula. Edema is swelling. So basically, fluid is being leaked out into that central part of vision. And that central part of vision is really, really sensitive. So any sort of fluid and structural changes in there starts to affect your vision rather quickly. So here is something called an OCT scan. This is where a laser goes in that does not damage the retinal cells at all, maps our cell layers. This is like biology class where we've cut the eye in half and we're looking in from the side. That little dip in the center is where all the light is focused in your eye, and you're always moving that little dip to what you're looking at because it's the most detailed part of vision. Here is the OCT scan of someone with diabetic macular edema. You can see instead of a dip, it looks a little bit more like a volcano. And the darker kind of bubbles in the middle there are fluid buildup. The little white specks that you can see, that would be things like exudate or little hemorrhages reflecting the laser back. This person's probably not seeing very well at all because that central part of vision is disrupted. This person is going to need treatment right away, and they would get sent to a retinal specialist. Luckily in State College, we have some really good retinal specialists. Geisinger has a retinal specialist, Dr. Cessna, who's fantastic. Then there's also a group called Pennsylvania Retinal Associates who Their main location is in Camp Hill, but they have an office in State College as well. They're also very good if we need to refer you out for retinal treatment. Here would be another example of diabetic macular edema. In the top picture, we can see our color picture of the retina. The white would be exudate, and then down below, we can see the OCT scan and all of the macular edema in there. So the main treatment these days for macular edema is actually an injection into the eye. And what that injection does is it targets that VEGF molecule again. So it binds up the VEGF molecule so that it can't get to the blood vessels. And that can really help improve the integrity of the blood vessels, to keep them from leaking fluid, to keep them from trying to grow new blood vessels. Diabetes does not only cause retinopathy and macular edema in your eye, it can also cause other issues or worsen other issues that you already have with your eyes. So a very common one is dry eye. So people who have burning, stinging, sandy, gritty feeling in their eyes, or their eyes are tearing up a lot on them, those are really common symptoms of dry eye. And when you have diabetes, it really just makes dry eye worse. And there's a couple of different theories. One is diabetes just worsens inflammation throughout your whole body, which dry eye is an inflammatory disease as well. And so they just work mutually to make things worse there. Another thing is that diabetes, I think probably most of us know people who have had neuropathy, which is where the nerves become damaged with diabetes, particularly in hands and feet. That can actually happen in your cornea too, where the nerves die in the cornea, and so the cornea doesn't heal up as well and can have more dry eye problems as well. Diabetic patients are at higher risk for developing cataracts or developing them earlier than other people. Cataracts, I think, are often easiest to see in real life, out in the real world, in old dogs. If you ever have an old dog, like a 13, 14-year-old dog, and you look at their eyes and inside their pupil just looks kind of cloudy, that dog has a cataract. What the cataract is the lens of the eye becomes cloudier and cloudier until it affects your vision and you just can't see clearly out. Luckily, cataract surgery is wildly successful and really quite easy to do these days. So that is a fixable problem. Diabetes can also cause something called glaucoma, where the pressure in the eye is too high for the optic nerve and pushes on the optic nerve and damages it. Particularly people with proliferative diabetic retinopathy, they can get new blood vessel growth in the drainage system of the eye, where all the fluid is released in the eye. And those new blood vessels will clog up that drainage, and so the pressure will just increase rapidly and really cause the patient a lot of pain and damage the nerve. And then another one that usually it's uncontrolled diabetes, where the blood sugar is really spiking up, it can actually change glasses prescriptions. I had a patient not too long ago who was on some oral steroid for I forget exactly what, for an infection or something. But their steroid actually kind of caused them to go into a diabetic state, and they were really thirsty, and so they were drinking a lot of sugary beverages, and all that extra sugar gets into the lens of the eye and causes the lens to swell. And when that lens changes shape, it can change your glasses prescription. So sometimes we'll see people coming in with uncontrolled blood sugar and their prescription will be wildly different. And then it's usually a waiting game of, all right, let's get the blood sugar under control and give you a month or two for your prescription to come back to where it should be. So what can we do to try to prevent developing retinopathy, or if you're a diabetic, just preventing kind of all your diabetic complications and getting better control of your diabetes? Cutting sugar consumption is probably still the #1 thing to do. I found it really interesting that in 1822, consumption of added sugars in our diet for the average American equaled about 12 ounces of soda every 5 days. Now we have so much added sugar in our foods that the average American consumes almost the same amount of sugar in every 7 hours. And what we also have to remember is that leads to high blood sugar in our body, which hurts our cells. It can lead to us being overweight, which we know is a risk factor for type 2 diabetes. And then sugar itself, particularly fructose, when it's metabolized in your body, can actually create extra inflammation, which can worsen everything as well. So reducing our sugar is important in the average American diet, and even more so in a diabetic diet. Exercising regularly, 20 minutes per day, also very important. It's really hard, especially as we do more and more sitting at a computer these days, but it's very, very important. I think one of the challenging things is a lot of our older diabetic patients, when there's comorbidities, so things like arthritis that make it hard to move, I think that can be challenging. So finding exercise methods that kind of help a little bit manage that, whether it be an elliptical or getting into the pool, those are things that we need to look at and work at doing. One thing other than diet and exercise, because I think everybody knows about diet and exercise, I'm sure we can all do better with diet and exercise. But one thing that often takes a backseat and we don't think about as much for diabetic control and our overall health is optimizing our sleep. There's been some studies out finding that if you're getting a lot less or more than your typical 7 to 8 hours of sleep, that can actually worsen type 2 diabetic situations. Up in the top left picture, we can see a patient sleeping with a CPAP machine. Another thing we need to think about, particularly in our diabetic patients, is sleep apnea. Sleep apnea would be another comorbidity that could worsen retinopathy or glaucoma, particularly in a diabetic patient. So that's kind of the summary for what we are looking for in our diabetic patients when you come in for a routine eye exam, and why it's important that we see our diabetic patients on a yearly basis, or if you were getting into moderate, severe, or proliferative retinopathy, we see you a lot more. To kind of save the vision, make sure that we can keep your quality of life from a vision standpoint at its highest possible degree for a very long time. Thank you.